Thank you, ma'am, and thanks for the opportunity. I will take you through the HER2 positive breast cancer space. So the first one is the FILA trial. So what is FILA? FILA is Cleopatra. Instead of pertuzumab, you have pyrotinib, which is a Chinese TKI. That is all. It is nothing but a Cleopatra, but you are substituting pertuzumab by pyrotinib. So just to tell you what were the results of Cleopatra. Progression-free survival in metastatic HER2 was 1.5 years. Overall survival 4.5 years. Remember, brain mets excluded, and this was the pre-TDXT era. Now in TDXT second line, you have a PFS longer than the first line, like 2.5 years. Overall survival 4.3 years, and did have brain mets, and previous THP was in 60% patients. Just to give a cap of what happened before. So what is pyrotinib? Pyrotinib is a Chinese TKI. It is a EGFR and a pan-HER2 inhibitor. It is irreversible, like lapatinib, which is reversible, it's not pan. So it is an irreversible pan-HER2 and EGFR inhibitor. If you look into this slide, if I combine trastuzumab with pyrotinib, the mechanism is something similar to PER2 TRAS2. It prevents homoheterodimerization. It binds to EGFR, HER2, HER4. So probably PER2 TRAS2 equals pyrotinib plus trastuzumab in the mechanism of action. Therefore, this FILA trial. So just to have a rough design how it is something like taxane, Herceptin, pyrotinib versus taxane, Herceptin. Just like the Cleopatra, before adjuvant TRAS2 should have been over at least 1 year before, and it did exclude brain metastasis, knowing that pyrotinib is very effective even in brain. Right, this is the design of the FILA. Something very similar. Pyrotinib is 400 milligram once daily orally with trastuzumab docetaxel versus placebo trastuzumab docetaxel. Primary endpoint being progression-free survival. The secondary endpoints are all these. So this is the comparison. Just remember that the treatment-free interval before adjuvant TRAS2 was 1 year and beyond. The progression-free survival. Remember, 1.5 years progression-free survival Cleopatra. Here it is 22.1 months. It is much longer than the Cleopatra, and you are seeing the curves wide apart right from the beginning itself. So pyrotinib is a very potent TKI, at least in Chinese population. The hazard ratio is 0.44, much more impressive than the Cleopatra. They looked into multiple subgroups. For those who had previous trastuzumab, the hazard ratios were much better than those who did not have. And also they looked into 1 to 2 years and 2 years and beyond. Even here, the hazard ratios were better if it was 1 to 2 years. So the overall survival also, like it is showing a trend towards statistical significance, but it is impressive. Yes, pyrotinib is as potent as pertuzumab. So these are the post discontinuation therapy. Just note TDXT, the right column, 4th row. TDXT was not given for any patients in progression. So that means the OS would have been much longer if TDXT would have been given. The response rates, like 84% response rates, is something phenomenal. It is much better than the Cleopatra. Duration of response also is very long. So this is a problem. Diarrhea is an issue with pyrotinib. We all heard of afatinib, dacometinib, which are pan-EGFR inhibitors, irreversible. So I have also used pyrotinib in some patients. It is not easy to give 400 milligram once daily. Even with 100 milligram, we struggle. Even though I've used in a subsequent line setting, not an easy drug to handle. Diarrhea is concerning for me. So you can just see the diarrhea. Even the grade 3 to 5 diarrhea is significantly high. Like 50% guys have grade 3 diarrhea, not an easy drug to handle. That's right. So what is my take on the FILA? So if I have pertuzumab, if I have pyrotinib, trastuzumab, and taxane, the positives are good CNS activity. Per2 TRAS2 doesn't get into brain, whereas pyrotinib is very effective in CNS. I will be happy to see the the time to development of CNS Mets would be a great endpoint in this. And one more thing is, if I have used PER2 TRAS2 before, there is down regulation of HER2 receptors. So for this reason, the subsequent ADCs, especially TDM1, may not work well post PER2 TRAS2. If I use a TKI, TDM1 may work better, and it is likely less expensive because it is a Chinese drug. The negatives are diarrhea is a real problem, and if I use pyrotinib, which is a very potential TKI early on, when to use tucatinib and lapatinib. So my final take on this trial is, I will use pyrotinib, trastuzumab plus pertuzumab only if I am not able to give pertuzumab for my patients. So if pertuzumab is not affordable or whatever reason, I can safely use pyrotinib with taxane and trastuzumab, provided the cost is much lesser and the patients can tolerate. The next trial is the TULIP trial. TULIP is HER2 positive metastatic breast cancer. It is trastuzumab duocarmazine, something like TDXT. It's a duocarmazine versus treatment of physician's choice. Just to compare the three antibody drug conjugates, we have TDM1, TDXT and trastuzumab duocarmazine. The chemotherapy moiety is this, emtansine, deruxtecan and duocarmazine, and the payload is the one that decides the bystander effect. So 1 to 3, 1 is to 3, but the problem is the linker is non-cleavable in TDM1. Therefore, you do not see a bystander effect. Whereas TDXT, excellent payload, cleavable linker, brilliant bystander effect. Whereas with duocarmazine, the payload is not that high, even though it has a cleavable linker. Therefore, the bystander effect is low. Therefore, in HER2 low, maybe duocarmazine is not that effective. This is the TULIP study design. So you have, this is the number for TDO. So it is 2 and beyond therapies. Remember, TDM1 was used in majority of patients. And what was the physician's choice? It did not have TDXT. It had CAPLAP, CAP-TRAS2, vinorelbine TRAS2 and eribulin TRAS2. So the comparator arm was not optimal. So this is how they placed trastuzumab duocarmazine. So just to have a summary, so they had, majority had 2 lines of therapy before. 60% patients used pertuzumab before. TDM1 was used before in 80% patients and 15% patients had brain mets. Remember, TDXT was not used before. The treatment arms, TDO versus sort of a suboptimal comparator, CAPLAP, CAP-TRAS2, vino-TRAS2 or eribulin trastuzumab. So patient had progressed on TRAS2 and I am giving TRAS2 again with chemotherapy backbone. No TDXT anywhere, whether in the previous or in the comparator arm. So this is the something similar which I said, like what are the baseline characteristics? The previous treatment was TDM1 in majority, right? So this is how the PFS, it is a positive trial. There is a modest improvement in PFS, 7 versus 4.9. It is not a game changer like a TDXT. There is a very modest benefit with a hazard ratio of 0.64. The separation is happening later on. Overall survival is not significant, 20 versus 16.3, hazard ratio is 0.83 and the p-value is insignificant. And you can see the subgroups, majority of subgroups are benefited. I would have been very keen in looking into brain lesions. Those who have brain lesions, I would expect ADC to act well, but it hasn't acted well. So it is not a ADC that is like TDXT that is going into brain, it's not that effective. So the response rates are in fact lesser with duocarmazine when compared to physicians of choice. Remember, the physician choice was nothing but a TRAS2 with a partner. In spite of that, the response rates are not great. So we understand this is because of the poor payload, just 2.5 payload along with trastuzumab. The problem is this, it affects the eyes. Conjunctivitis and keratitis is really concerning with duocarmazine, therefore it's not easy to use. Quality of life looks okay. So the conclusion is, duocarmazine had a modest improvement in PFS from 5 to 7 months, no significant OS difference. Response rate was less than the comparator arm. Eye toxicity is a problem. Remember, TDXT had a PFS of 18 months. Here it is 7 months in the similar setting. So my take, trastuzumab duocarmazine is not a game changer like TDXT. Eye toxicity is a problem. The comparator arm was suboptimal. It should have had TDXT, tucatinib or pyrotinib. We may consider post TDM1 if we do not have access to TDXT or tucatinib. Thank you.